Ken Landau. Thanks for watching. Let's talk about temazepam, also sold as Restoril. This is a sleeping pill. It's in the Benzodiazepine family, so it's a class 4 controlled substance used for the short-term treatment of insomnia. It was synthesized in 1964. FDA licensed it in 1969. By the late 1980s, it was one of the most popular hypnotics that was sold on prescription here in the United States. Still one of the most frequently used benzodiazepines. Actually, it's number 5 on the list, right after Xanax or alprazolam and lorazepam and diazepam, Valium, and clonazepam, Klonopin. Then is Restoril. Restoril comes in a variety of different strengths, most popular of which are 15 and 30 milligram. And because of the potential for oversedation or dizziness or confusion or ataxia, difficulty walking, you should begin at a relatively low dose, especially in an elderly or debilitated group of individuals. You have to be extraordinarily cautious if a person has depression. Well, typically we begin an adult at a dose of 15 milligrams. Some need higher, some need lower dose. If the issue is sleep latency problem, in other words, you go to bed but you can't fall asleep, low dose can suffice. If you have transient insomnia, low dose can suffice. But to some extent, the dose and duration of the drug has to depend on the genetics of the individual, the type of insomnia you suffer from, and the potential for hazards in the morning. Now, if you take the Restoril, because it's a relatively longer acting sleeping pill, you should have at least 7 to 8 hours where you can remain in bed, where you don't get up and drive the car, don't operate any hazardous machinery during that period of time. The United States Air Force says that pilots can't fly their planes if they've taken Restoril within 12 hours, or on the other hand, Ambien within 6 hours, Sonata within 4 hours. So the drug is used for the short-term treatment of insomnia. Generally, that means 7 to 10 days. Clinical trials in support of the drug lasted about 2 weeks. Seems that in the normal dose range, the more you take, the better off you are, at least if we're talking about an increase in total sleep time and a decrease in sleep latency. So you sleep more and it takes you less time to fall asleep, especially at the 30 milligram dose. 7.5 milligram dose, not usually very helpful. Generally, it's not used in those individuals less than age 18, not because of any specific harm, just because it hasn't been studied. It seems that we can talk about sleep as delayed sleep onset, that's that sleep latency, frequent awakenings during the course of the night, and you could have non-restorative sleep. In other words, you sleep the night, but you really feel kind of blah in the morning. Well, most people have several of those different types. So if you look individually, about 1/3 of the people have difficulty falling asleep, about 60% of the people have difficulty maintaining the sleep, in other words, they get up in the middle of the night, and about 50% of the people are going to have early morning awakening. Well, half of the people, like I say, have 2 or more of those. Now, if we look at sleep onset insomnia, more common in younger adults, but they tend to grow out of it. On the other hand, sleep maintenance problems, so you wake up multiple times during the course of the night, that's more in middle-aged and older individuals, and that seems to be more persistent. Now, because the benzodiazepines might cause fetal harm in pregnant women, might actually pass through the placenta, it's not recommended in pregnancy. Well, not everybody who has difficulty sleeping should take a sleeping pill. So if you have lack of coordination or acute narrow-angle glaucoma, if your liver or your kidneys don't work right, if you have respiratory problems like COPD or severe hypoventilation or sleep apnea, the drug's not for you. Severe depression, not for you. If you use alcohol in excessive amounts, shouldn't take the drug. Myasthenia gravis, shouldn't take the drug. And you have to be extraordinarily careful if you're taking it with other drugs that might act as central nervous system depressants. So that includes the barbiturates, tricyclic antidepressants, the MAO inhibitors, the antipsychotics, the smooth muscle relaxants, antihistamines, opioids, alcohol. Have to be careful with all of them because they might increase the risk of negative side effects. Now, the pill itself once you take it, it's well absorbed. About 96 to 100% is going to be bioavailable. 96% is going to be bound to the plasma protein. About 8% is going to be metabolized through the liver in the first pass as it goes from the stomach to the liver, or the intestines to the liver. It's going to be metabolized in the liver by conjugation and demethylation. About 80 to 90% of the chemical is going to appear in the urine with no active metabolites. It would appear that the blood levels of the parent drug seem to decline in a biphasic manner. So in other words, it has a very short initial half-life of about half an hour. But then the terminal half-life is somewhere around 9 hours. Could range anywhere between about 4 hours and 18 hours. Significant variation, obviously. But it tends to be that there's a relationship in the area under the curve, the amount in your blood, on the basis of how much you take. Now, at the 30 milligram dose, we're going to have measurable plasma concentration within 10 to 20 minutes and peak level in about an hour and a half. And if you take the pill, 30 milligrams, about an hour before retiring, going to get to a steady state by the third day. Doesn't seem to invoke any drug metabolizing enzymes, so that's good because that means that there's a decreased risk of reaction with other drugs, at least as far as their metabolism is concerned. Now, when we talk about the benzodiazepine sleeping pills, we can talk about short half-life, long half-life, and intermediate half-life. Well, a short half-life means the drug is going to be cleared at a range of less than 4 hours. So it's going to be cleared before you take your next dose. Not going to have any significant effect when you wake up in the morning, not going to cause you to be sedated, not going to have CNS depression, central nervous system depression. But unfortunately, it might lead to wakefulness in the second half of the night. Well, if you take the long half-life, where the half-life of the drug is more than 20 hours, drug's going to accumulate, possibly impair your cognitive performance, your motor performance. So obviously you have to be careful. Well, it seems that Restoril might be a good drug that fits right in the middle. Now, if you take it for too long a time period, you might develop some kind of tolerance, and there is some evidence that it might lose its effect. Now, temazepam itself, Restoril, doesn't seem to cause any change in the REM sleep. It decreases the slow wave sleep. Residual hangover effects essentially absent. So it doesn't seem to have any measurable effect on daytime alertness or performance. Doesn't seem to have any significant withdrawal in the overwhelming majority of people. And it reduces your early morning awakenings, which is especially important in middle-aged and older people. And unlike most of the other benzodiazepines, the exception being lorazepam and oxazepam, it doesn't interfere with cytochrome enzymes in the liver. So that means it doesn't seem to have any significant effect on other drugs, except if you happen to be taking an oral contraceptive and it has a testosterone type product. Well, it might increase the metabolism of that. And that can cause problems, especially if you're taking the birth control pill to be effective so that you don't get pregnant. Well, the drug's not carcinogenic, it's not mutagenic, it doesn't change fertility. Shouldn't take it if you're pregnant, shouldn't take it if you're breastfeeding, pediatric use, uncertain, not to be used. In the geriatric population, well, there's not all that much difference between the geriatric population and the average adult population, except that elderly individuals often have some sort of a decrease in the liver or the kidney function or cardiac function, and as a result might lead to some oversedation or confusion or lack of coordination or even falls and then hip fractures. Well, there's a black box warning, and the warning suggests that you shouldn't take the drug with opioids. Because if you take the two together, you might have profound sedation and respiratory depression, coma, and death at a rate greater than either one of the drugs by itself. So if you really need to combine the two drugs, should limit the dose, limit the duration, and you should be carefully followed for the respiratory depression and excessive sedation. Now, if we ask people who are taking temazepam, how did you sleep? Well, they're going to say that their sleep latency, the time from going to bed to falling asleep, was reduced by about 20 minutes. But objectively, if they're studied quite carefully, it seems there's about 37-minute reduction. If we ask for the total sleep time, people say, well, I slept about an hour more than I would have if I didn't take the pill. But objectively, it's an increase of about 100 minutes. Now, you have a variety of different kinds of sleeping pills. So Sonata has a half-life of about an hour to an hour and a half. Triazolam or Halcyon, 2 to 6 hours. Ambien, about 2.5 hours. Lunesta, about 6 hours. Temazepam, anywhere between 8 and 15 hours. Balsamra, about 12 hours, so have to be a little bit more careful of that. Doxepin, that's getting to be very popular, has a half-life of about 20 hours. So that's going to still be significantly present in your blood the next day. Melatonin, on the other hand, has a half-life of about 3/4 of an hour. So when a person suffers from insomnia, sleep disturbance, question always is a manifestation of some underlying physical, underlying psychiatric abnormality. So they need to be evaluated certainly before therapy, and if it seems that the treatment doesn't cause the insomnia to resolve within a week or two, you need to be reevaluated. Sometimes, even though it's a sleeping pill, even though you think it knocks you out, you can have a paradoxical reaction. So it can decrease the inhibition. Same thing in some people who take alcohol. So you can become aggressive or become extroverted, out of character, bizarre behavior, agitation, hallucinations, even depersonalization. Can have some complex behaviors like sleep driving, where you drive while you're not fully awake and then you have an amnesia for the event. And that occurs in both people who are starting the drug and people who have taken the drug for some time. It's rare with temazepam alone, but it's more common if you drink alcohol, if you take any of those other CNS depressants that I mentioned a moment ago. And the more you take, the higher the dose, the greater the likelihood of the problem. So other kind of reactions, people can develop some amnesia or some neuropsychiatric symptoms. Some people who have depression actually worsen their depression. And we have difficulty determining sometimes when the person has these other underlying either psychiatric problems, medical problems, if they take the pill and have the side effect. Was the side effect due to the medicine, or is it due to one of the conditions that they also have? Withdrawal symptoms? Well, it all depends. Theoretically, the same as with the barbiturates and the alcohol, where you can get convulsions and tremor, abdominal muscle cramps and vomiting. Sometimes people sweat excessively. But that's in people who are taking the standard benzodiazepines multiple times a day, typically. You have a much milder withdrawal, if any, if you're taking Restoril once a night. Some people have some insomnia, but the insomnia probably is just the symptoms coming back, or dysphoria. If you're taking more than 15 milligrams, it might be worthwhile tapering the dose. Anaphylaxis, allergic reactions to the medicine, yeah, possible, but pretty doggone rare. Swelling of the tongue or the throat can occur with first dose or subsequent doses. Some people have dyspnea, or they feel like their throat's closing, or they develop nausea or vomiting. But the routine adverse reactions when you take temazepam or Restoril, sometimes you get a little drowsiness or lethargy or dizziness, hangover, that's sleepiness in the morning, less than 2 or 3%. That has to do with impaired psychomotor cognitive function, impaired driving ability. Some people become anxious, about 2%. But actually, in the studies, people who are taking the placebo had a greater incidence of headache and depression and dry mouth and nightmares than the people who were taking the Restoril. But you have to be a little bit careful, especially if you're elderly, because it can impair your body balance and the steadiness, especially if you wake up at night and go to the bathroom. Maybe you fall, maybe you have a hip fracture. And then, as I mentioned, there's some tolerance that develops. Longer reaction times possible, slurred speech, inattention, anterogrowth amnesia. Well, the federal government says tolerance may develop after you take the medicine for about 3 to 14 days. And that's sort of been what everybody has said. But you have to consider what the underlying type of insomnia is. And now we know that insomnia is a disease by itself. And in some people who have a genetic type of insomnia, lifelong insomnia, their parents, mother or father had insomnia, grandparent had insomnia. Well, if you have insomnia, it's going to last for a long time, and then you need some sort of a crutch. And this might be appropriate. You can overdose on the medicine. If you overdose, you have some somnolence or confusion, or some people have decreased or absent reflexes, respiratory depression, blood pressure falls, motor function is abnormal, decreased coordination and balance. Some people have some dizziness or sedation. It's possible to take a fatal overdose of temazepam or Restoril, but if you're taking the drug by itself without the opioids, without the tricyclic antidepressants, or without any of those other drugs, chances are you're just going to sleep. Abuse, it's not widespread in the United States. In Australia, they had such a problem with the drug from an abuse standpoint that they took the 30 milligram capsules off the market, left only the 10 milligram tablets on the market. United Kingdom, it's one of the most popular abused benzodiazepine, especially with the polydrug abuse. The way it works, well, it promotes sleep, works through the GABA neurotransmitters, and it also antagonizes the receptors for the wake-promoting monoamine. So there are chemicals in your blood that tend to keep you awake. And the Restoril stops those chemicals from reacting. That's why it might be useful for a relatively long-term dose. Now, if we categorize insomnia, we could say have acute insomnia, by definition, less than 4 weeks, typically due to stress or change in the medicines you're taking or ill health. You can have repeated episodes of acute insomnia, or you can have chronic insomnia that lasts for more than 4 weeks. You have to consider, well, are you doing something that's causing the insomnia? Or maybe it's stress, maybe it's anxiety, maybe exercise right before you go to bed. Maybe you have too much coffee, soda. Maybe it's a childhood onset condition with family history like I was mentioning. Well, the treatment for insomnia is sleep hygiene. So don't have alcohol, don't smoke cigarettes, go to a quiet, darkened bedroom, get some bright light in the morning to help set your circadian rhythm pattern. Some people go for cognitive behavioral therapy. It takes a long time, but it's somewhat effective. And it's effective even after you stop the therapy. Unlike the pills only work while you're taking them. We have other medicines that are used, other pills that aren't traditional sleeping pills. So some people take the sedating antidepressants, like we talked about with the doxepin or the amitriptyline or the mirtazapine. Some people even are now pushing the sedating antipsychotics. I think that's a horrible idea, like Abilify or Restoril or Zyprexa. Some people take the sedating antihistamine. Some people take melatonin, which typically doesn't do much of anything. So insomnia is now thought to be a disease in its own right. Definition: occurs at least 3 nights per week, occurs for at least 3 weeks. And then some people divide it into insomnia symptoms. That's more the transient insomnia that probably somewhere around 1/3 of the people in the world are going to suffer. But then some people refer to insomnia disorder. This is persistent, lasts for months to years, and the prevalence is about 10%. Now, there are a lot of people who are against taking sleeping pills. But you have to consider, if you have persistent insomnia, it might decrease the quality of life for the rest of the day, lead to some physical and psychological morbidity, lead to a decrease in your function in the daytime and fatigue and decreased energy and mood alteration, decrease in cognition and attention, decrease in your memory, your concentration. Chronic insomnia is a major problem that we have to keep a relatively close eye on. Now, it's a clinical diagnosis. It doesn't need a sleep laboratory, doesn't need any fancy kind of testing. And all that talk about the sleep hygiene, where you sleep in the dark room, it's quiet, and all, rarely ever seems to be very helpful. Now, insomnia is more common in women than it is in men, but it's also common in children and adolescents. Prevalence actually seems to be the same in young people and older people. Older people just have more sleep fragmentation. In other words, they get up more at night, whereas the younger people, they tend more to suffer the sleep latency disorder. The older people, by the way, are less apt to report that they have a decrease in daytime function if they have insomnia. Well, now studies suggest that about 30% of the people with insomnia have positive family history. So the heritability of the condition from twin studies seems to be somewhere in excess of 30%, maybe up to 60%. So that's the story of Restoril or temazepam. It's a commonly used sleeping pill. It's been time tested, appears relatively safe. But there's currently a governmental induced tendency to vilify sleeping pills. They think of them as dangerous and the cause of an enormous list of significant side effects. But they forget to talk about the side effects of insomnia and the negative impact that insomnia can have on an individual's life. Now we recognize that not all insomnia is the same. There are a variety of different causes of insomnia, and especially in those individuals who have the genetic type of insomnia that's going to go on for a long period of time. Well, a sleeping pill for 7 to 10 days or 7 to 14 days isn't going to cut it. You have to take it for a long period of time. So consider the medicine as appropriate for some people, inappropriate for other people. Pick the medicine on the basis of the half-life. If you have a problem falling asleep, you want one kind of medicine. If you have a problem staying asleep, maybe a different kind of medicine. So a lot of people take Ambien. Ambien will help get you to sleep, but oftentimes won't keep you asleep through the night. Restoril, on the other hand, it does 30 milligrams, helps you get to sleep and stay asleep. Anyway, thanks for watching. If you enjoyed the show, please tell a friend or consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.